Good morning, class. Our topic for discussion today is on tracheostomy. So what is tracheostomy? Tracheostomy is the creation of a permanent or semi-permanent opening in the trachea to maintain airway patency. It is done in patients who are critically ill and who require prolonged mechanical ventilation for acute respiratory failure. Now, prolonged translaryngeal endotracheal intubation increases the risk of ventilator-associated pneumonia. It can also cause contamination of the bronchial tree, and it is associated with the development of sinus. There can also be severe laryngeal and tracheal damage, as a result of which tracheostomy is an alternative to prolonged endotracheal intubation. Coming to the history, it is first mentioned in Rig Veda in the 2000 BC, and it has also been described in Egyptian manuscripts 3,500 years ago. It was Hester who first introduced the term tracheotomy, and it was Negus who coined the term tracheostomy. Now, there are two types of tracheostomy. There is temporary tracheostomy and permanent tracheostomy. There is also elective tracheostomy and emergency tracheostomy. The opening that is formed is called as a tracheostoma, and it is a permanent opening into the trachea through the neck. Coming to the indication is impending upper airway obstruction, which can be due to infection, trauma or pathology, major laryngeal trauma like vocal cord fracture, prolonged intermittent positive pressure ventilation requiring the patient to be on artificial ventilation, inability to intubate or perform a cricothyrotomy, laryngeal foreign body or pathology, hypercarbia, hyperoxemia due to frail chest or lung contusions, and also it is performed for control of cerebral edema in head injury patients when they are put on artificial ventilation. The mechanical obstructions can be due to congenital reasons, which is subglottic or upper tracheal stenosis, laryngeal web, tracheoesophageal anomalies, or hemangioma of the larynx. It can be due to infective causes, which can be acute epiglottitis, the laryngotracheobronchitis, diphtheria, or Ludwig's angina. It can be due to malignancies like advanced tumors of the larynx, tongue, pharynx, or upper trachea, causing stridor. It can be due to trauma, which is a gunshot or even a knife wound to the neck, causing, it can also be due to inhalation of steam or smoke or swallowing of any corrosive fluid. Vocal cord palsy due to post-operative complication of thyroidectomy, cardiac or esophageal surgery, or bulbar palsy. It can also be due to the presence of foreign body which has been swallowed or inhaled objects in the upper airway, which can cause stridor. Other indications are neurological diseases like polyneuritis, like the Guillain-Barré syndrome, or the motor neuron diseases. Also in comatose patients who have a Glasgow Coma Scale less than 8, who has a greater risk of aspiration. In respiratory failure like pulmonary diseases or flail chest, patients with retention of secretions, or elective tracheostomy as an adjunct to head and neck surgeries. The procedure involves anesthesia, incision, and positioning. First, in anesthesia, the patient can undergo this procedure under local anesthesia or general anesthesia based on the situation. So, based on the situation, this can either be an elective procedure or an emergency procedure. So, the incision is also directed based on the procedure. Now, incision is either transverse or longitudinal. Transverse incisions or horizontal incisions are placed in case of elective tracheostomy, whereas vertical incisions are preferred in emergency tracheostomy. We position the patient in a supine with a shoulder pad and a head ring so as to keep the neck extended. The skin is prepped using povidone iodine. The patient is draped. Good light source and suction machine is kept ready. And blunt dissection of the subcutaneous tissue is done transversely after an incision which is placed in the 2 to 4 centimeters below the cricoid cartilage or 2 to 4 centimeters above the suprasternal notch. This is the area of the incision. The incision length is based on the length of the anterior border of the sternocleidomastoid muscle laterally. So once blunt dissection is done subcutaneously, the strap muscles are divided at the midline. and using a Langenbach retractor, it is used to be retracted laterally. Now the thyroid isthmus is divided. If not divided, it can be either superiorly or inferiorly positioned, and this is secured using 2-0 vicryl. The thyroid is then retracted superiorly, and depending on the size of the tracheostomy tube, about 4 cm longitudinal opening is made into the trachea below the second tracheal ring. The tracheostomy incision is preferred below the second tracheal ring and above the fourth tracheal ring. Now the Negus tracheal dilator is then applied, and the tracheal tube is inserted in between. The tracheal tube is then anchored, and it is kept in position using sutures or tracheostomy ties. This is the procedure showing the tracheostomy. Here it is done as an elective procedure with a horizontal incision. Coming to pediatric tracheostomy, here a vertical incision is preferred in the trachea between the second and the third tracheal rings, and there is no excision of the anterior wall of the trachea. The tube is secured using 2 sutures at the neck. I mean the types of tubes. The types of tubes are cuffed tubes, you have uncuffed tubes, fenestrated tubes, inner cannula, adjustable flange, PVC, silver, silicone and rubber tubes, and many tracheostomies. This is the metallic tubes coming in different diameters. The fenestrated tube, it allows the patient to ventilate past the tube via upper airway, and it allows speech. Coming to the cuffed tubes, it allows ventilation and prevents aspiration. High cuff pressure can be damaging to the trachea, and it should not be blocked at any cost. Coming to indications of a cuff tube: risk of aspiration, newly formed stoma in an adult, positive pressure ventilation, and in an unstable condition. Contraindication is used in a child who is less than 12 years of age and who has a significant risk of tracheal damage from the cuff. Coming to uncuffed tubes, it maintains airway once aspiration risk has been passed, increase airflow to the larynx, and it is done in patients who require long-term tracheostomy, patients who do not require a seal, and in pediatric patients. Its indications are vocal cord palsy, head and neck tumors, respiratory insufficiency, neuromuscular diseases, pediatric or neonatal tracheostomies. Contraindicated in patients who are dependent on positive pressure ventilation, who has a greater risk of aspiration, and a newly formed tracheostomy. These are neck collars which are used to secure the tracheostomy tubes. Coming to cricothyrotomy. So what is cricothyrotomy? It is an emergency procedure which is carried out in order to maintain airway patency. And here an incision is placed below the thyroid cartilage and above the cricoid cartilage at the region of the cricoid membrane. Here the cricoid membrane is opened and a cricothyrotomy tube is placed in position. So cricothyrotomy, as I said earlier, it is an emergency procedure because it is way easier to carry out than a tracheostomy. But this has to be converted to a tracheostomy because this can only be kept in place for 3 to 5 days. The complications of cricothyrotomy includes subglottic edema, surgical emphysema, perichondritis, infection, vocal cord injury, and stenosis. Coming to what is percutaneous tracheostomy. Percutaneous tracheostomy is performed using a flexible bronchoscope, and this is a procedure of choice in adults in the ICU who require elective tracheostomy. So here a small skin incision is placed between the second to third tracheal rings. Some blunt dissection is done and a 14 gauge cannula is placed with a syringe. A guide wire is placed through the cannula, and the trachea is dilated using dilating forceps, and a tracheostomy tube is placed with an obturator. The contraindications is in children, people with bleeding diathesis, previous surgery, and infection, and it is dangerous to be done in patients who have short neck, thick or fat neck, and enlarged thyroid swelling. Coming to complications of tracheostomy, this can be intraoperative, early or late. Intraoperative complications include bleeding and injury to big vessels, injury to tracheoesophageal wall, pneumothorax, apnea, and cardiac arrest. Early complications include bleeding, tracheostomy tube obstruction, tracheostomy tube displacement, and infection. Late complications include tracheal stenosis, granulation tissue, tracheocutaneous fistula, and tracheoinnominate fistula. Coming to the problems faced during tracheostomy care. So the most common problem here is a dislocation of the tracheostomy tube. You can also have bleeding from the stoma or during suction. There can be blockage of the tracheostomy tube, aspiration or swallowing problems, speaking problems, and decannulation problems. How do you suction a tracheostomy tube? You can connect the catheter to a suction machine. You should not touch the end of the catheter, that will go into the tracheal tube. You insert the catheter into a proper distance into the tracheal tube, and you apply suction by putting your thumb over the hole of the catheter while you gently pull out the catheter back. So this is how suctioning of the tracheostomy tube is done. Decannulation. Decannulation is a procedure of removal of the tracheostomy tube when the patient no longer requires this. This can be done as a stepwise procedure. So first is to uncuff the tube, and downsizing of the tube is done if it's necessary, and after this an airtight dressing is placed. So with that we come to the end of today's discussion on tracheostomy. So thank you, class.